The receptors for the sympathetic nervous system, we have adrenergic receptors. The adrenergic receptors sound like the word adrenaline, so it makes sense that these are sympathetic. The adrenergic receptors are alpha receptors or beta receptors. Alpha 1, alpha 2, beta 1, beta 2, and less important to our discussion today, beta 3. This is important in your practice. Where I think about it the most is probably in critical care, where you need to know whether or not your drugs are selective. Your management of that patient comes down to whether or not you might be able to stabilize the hemodynamics of the patient. Some of these medications, the beta blockers, some of the drips that we use, it is very important to know whether or not there's an alpha 1, alpha 2, whether renal receptor effects. Drugs like norepinephrine and epinephrine that we use for pressor support in the ICU, remember that sometimes there's quite a bit of overlap as to whether they may be A1 and A2 or B1 and B2. And sometimes that's a problem because you really only want an alpha receptor, an alpha effect or a B1 receptor effect. So look at A1. A1 is vasoconstriction. It increases peripheral resistance. These two go together, right? So this is increasing the afterload effect. It increases blood pressure. Vasoconstrict the peripheral vasculature. You are, by definition, going to get increased peripheral vascular resistance that you can measure, and you will see an increase in blood pressure. Mydriasis, so what does that mean? Good, pupil dilatation. And then increased closure of the internal sphincter of the bladder. Well, that's not a surprise, is it? Now with the A2 effects, so the A2 effects are pretty limited. And notice it's almost counter to A1. So it's going to inhibit, and actually the A2 is part of this negative feedback system. So that's why A2 is a little bit confusing because it's an alpha receptor. So inhibition of norepinephrine release, inhibition of acetylcholine release, and then inhibition of insulin release. Now the beta 1 and beta 2, very easy. Beta 1 is primarily heart. So if it's primarily heart, we would expect to see an increase in heart rate. We would expect to see an increase in contractility, increased release in renin for the RAS system, good, and then an increase in lipid breakdown. What's the advantage of lipid breakdown? Well, more energy. Use another pathway to produce ATP. So we've got an increase in heart rate, we've got an increase in contractility. So these are the drugs that are going to increase cardiac output. And we'll get to that in a minute, some examples. Increase in renin, well, that can give us a little bit of an increase in blood pressure. Not necessarily an effect that you might expect, maybe counterintuitive. This is one that you're going to have to remember. What happens when you increase renin? It's going to increase blood pressure. The beta 2, bronchodilation, increased muscle and liver glycogenolysis. Well, that's helpful because it's going to give me glucose, and glucose gives me ATP. If I increase my cardiac output, I want to mobilize ATP. Increased release of glucagon, well, it has the opposite effect of insulin. Relaxed uterine smooth muscle, which of these do you think you're going to forget on the test? Probably the uterine smooth muscle. It doesn't fit nicely in the rest of these processes. And then also you need to remember increased release of glucagon. Okay, so our types of adrenergic receptors, this is a nice, convenient slide. Here we get into some drugs. Epinephrine. Now, when do we use epinephrine? Well, we use it in a code situation, cardiac arrest. It's that 1 milligram that we give, push. That's when we see it used. But we also use it in the ICU in patients septic patients, for example, who may have failed to respond to norepinephrine. So these are our sickest patients that we might have to use an epinephrine drip. The other time you might see it used, for example, is in the cardiac critical care unit. That being said, look at the crossover effects that you get with epinephrine. Epinephrine is an older drug, and look at the crossover. It affects all 4 of the receptors. So we say that it's non-selective because it just across the board, it's going to affect all of these, which means that if you give epinephrine, you have to accept beta 1 and beta 2 activity as well as alpha. There is no selectivity here. So let's say you want to give a drug because the patient's blood pressure is 70/50, and you really want to affect their blood pressure, but you're going to get tachycardia. Now, you might say, well, that's not a problem because I want to increase the blood pressure. But it could be a problem if your patient has had a recent MI. You only want to affect the blood pressure, and you really want to save the heart, right? And by giving epinephrine, you have no control over that effect. That's the disadvantage of giving non-selective drugs. Now, with norepinephrine, we like norepinephrine a little bit more. What about a drug like dobutamine? We give it in patients with heart failure, patients that we want to increase ejection fraction. Now, the side effect of dobutamine is that you get some vasodilatory effects. That's a side effect, but it's not a dominant effect. The primary effect of dobutamine is it's highly selective, and it does exactly what you want. It focuses on the heart. So why do we like phenylephrine? This is the drug that we tend to use in patients that have neurogenic shock. What do you notice about the advantage of phenylephrine? Well, it's purely alpha 1. So if I just want to bring up the patient's blood pressure, and I don't want to affect the heart, then I might use a drug like phenylephrine. It's highly selective. Now, what about this drug clonidine? When do we use that? Well, that is something that one could use as an outpatient blood pressure medication, clonidine. But notice what clonidine does. It's a blood pressure medication, so it's going to lower the blood pressure, but the only downside of clonidine is it's so specific and so effective that it can lead to orthostatic hypotension. One of the reasons why clonidine is not a first choice. What is terbutaline? Terbutaline is a medication that we use in obstructive lung disease. Notice how selective it is in terms of beta-2 effects. So we get very specific bronchodilatory effects. I would say if I were memorizing for the exam, I would make sure that I know these selected drugs and know what they're selective for. There's one drug that's been given to you that's alpha selective. We've got an alpha 2 selective, a beta 1 selective, and a beta 2 selective. I think high yield for the exam. Why is epinephrine unique? Because it affects all 4 of the receptors. Norepinephrine is important because norepinephrine is also known as Levophed, and you may remember from your clinicals how often do we use Levophed in the ICU for blood pressure? All of the time. In many ICUs, it's first line. So do I think that you're likely to see a question here? Yes, because it is so clinically relevant. Remember, it's both alphas and beta 1. Now with isoproterenol is, I think, testable because it's one that's beta 1 and beta 2 only. MAO inhibitors, there are some downsides to MAO inhibitors in terms of drug interactions, so they're not used as much as maybe a more common like an SSRI. Very, very common now in terms of it has price point, they're inexpensive, and they're safe. So you will see SSRIs used more than you will see MAOIs. Now, big change, we're talking about adrenergic receptor antagonists. Another word for antagonist, blocker. So we've got some alpha blockers, and we've got some beta blockers. The beta blockers you're very familiar with already. Based on the ending, these are easily identifiable. What's important here is whether or not they're selective or non-selective, and the selectivity predicts what patients they're most appropriate for. So these are the non-selective. Propranolol, very commonly used for blood pressure, very safe and very affordable. Now we've got some beta 1 selectives. Atenolol. Atenolol is one that's used quite a bit. Esmolol is used very short-acting, used in the ICU. You can sort of turn it on and turn it off, so that's why esmolol is popular. It's short-acting. Metoprolol is another one that we use as an outpatient. So the ones that we see in the community most often, atenolol and metoprolol. So dopamine is another drug that's used in the ICU. It's really only used in the ICU because it is a drip. And this drug can be used to support renal function, it can be used to support blood pressure, and it can also be used to support cardiac function. So dopamine is kind of an interesting drug because depending on what you set your dosage at, you get a different effect. You know, a drip means that you're giving a steady amount in the bloodstream intravenously per hour. And when you set that drip rate low, you're going to have primarily effect on the renal receptors. And it increases renal blood flow. And then albuterol and salmeterol, so we've got here drugs that are used as inhalers. Salmeterol as a long-acting, but they are bronchodilators. Ephedrine and pseudoephedrine, very common outpatient medications that we take for cold and upper respiratory symptoms. Phenylephrine is typically the drug of choice for neurogenic shock. Now, what do I mean by neurogenic shock? It's a very specific kind of shock. Neurogenic shock is shock that occurs from spinal cord injury. The alpha 2 agonists, methyldopa is used for blood pressure medication. Etomidate, it is a medication for sedation, but this is the generic. So dexamedetomidine. And then methyldopa we have not talked about, but you should remember that it's used for hypertension. The downside of methyldopa, so why do you not see methyldopa on the drug list for most patients that are going to come into your office? It is because it can also cause orthostatic hypotension. So these alpha drugs that we use for blood pressure, you notice they're not as popular as the beta blockers. And it's because it's for this reason. Now you will see methyldopa used in the treatment of gestational hypertension. That tells you something about whether this drug is safe in pregnancy. I would remember methyldopa as being a drug that you can use in gestational hypertension. Focus on respiratory medications. So I do think that the importance here is that you remember that bronchodilators are beta 2 receptor agonists. Whenever you see beta 1 from now on, you should think heart. Whenever you see beta 2, you should think about respiratory effects. Most common drugs are going to be all of these inhalers that you're going to learn. Adverse effects. So lots of adverse effects, and students always struggle with remembering adverse effects. But if you keep in mind that many of the adverse effects are effects because of either their primary effect, receptor effect, or their crossover effect, right? So the fact that they're non-selective may give you some of the adverse effects and will help you remember those. So let's take, for example, so most common side effects for patients are changes in heart rate and blood pressure. And that's true. So you give a medication for, it's a GI effect, and it leads to either tachycardia that makes the patient uncomfortable, or less commonly, a drop in their blood pressure. It leads to palpitations, racing heart, uncomfortable for the patient, just a side effect of that medication. Why? Because maybe there's a crossover effect, alpha-1 effect, or a crossover beta-1 effect. So the more selective the drug, the less adverse effects. So that's why these newer drugs, many of the times, they're designed to eliminate this non-selective effect, and that's to eliminate some of these side effects. So we can take a selective agonist binding to an alpha-1 receptor, leads to hypertension. That makes sense. So if you can, so you see the connection here in terms of how you can memorize pharmacology. If you can remember the drug and the receptor effect, then you don't have to remember each drug and each adverse effect. You can say, oh, well, this drug is an alpha-1 and a beta-1, or an alpha-1 and an alpha-2. Therefore, this drug is going to have the following adverse effects. So if you can put these drugs sort of in categories where you know what their receptor effect is, then it makes it a little bit easier. So we have certain drugs that bind to alpha-1 receptor, such as phenylephrine, that may lead to reflex bradycardia. In other words, the body's response to that elevation in blood pressure. So the body will reflexively. Now, is that always a problem? No. Phenylephrine may raise the blood pressure, but maybe your heart rate goes from 86 to 72 or 66. Still within the range, but what he would define as reflex bradycardia. It doesn't necessarily mean that you have to lower the dose or stop the drug. It's just something that you need to be mindful of. Then we have these drugs that selectively bind to alpha-2 receptors, and they may cause, as a result of binding to alpha-2 receptors, what you would expect. They may cause hypotension, they may cause dry mouth and sedation. At higher doses, respiratory depression. What are some adverse effects of beta-1 receptors? So why are we giving beta-1 receptors, beta-1 drug? For the heart. And we talked about dobutamine. So the selective binding of the beta-1 is that they're going to activate those beta-1 receptors. So we would expect an increase in heart rate. And we may even get some hypertension. In patients that are especially sensitive, they may get tachyarrhythmias, tachycardia, which is a sinus rhythm. It's an increased rate. You can also get other tachyarrhythmias that are much more concerning. Here we just want to know that tachyarrhythmias, when you're stimulating the heart, can result. Now, anxiety is an effect that, the patient feels. So he feels the palpitation, the racing heart. High doses can cause dangerous arrhythmias. And then beta-2 receptor agonists. So they can cause tremors, tachycardia, palpitations, and anxiety. Notice that the adverse effects for beta-1 and beta-2 are similar. Okay, so you can group those together. It is very common for patients, when you use an inhaler, who use an inhaler regularly, to complain about the side effect of albuterol. It's more with albuterol than with salmeterol, but they feel that racing heart. And they're really taking it for the bronchodilatory effects. So a little bit tight airway, maybe COPD patient or an asthma patient, but they will have that side effect of racing heart. That the way we have improved upon that is with a drug that's called levoalbuterol, and that is a drug that is more selective, and patients experience less of this effect. Now, the downside of levoalbuterol is its expense. It's more expensive. This is the drug is called Xopenex. I'm not sure if you remember seeing it prescribed. So albuterol, very traditional, low-cost inhaler. But if you give a patient Xopenex, that's going to add onto the cost. It's quite a bit more expensive than just the traditional albuterol. But for some patients, it's worth it. And maybe in patients who have cardiac risk factors, you may prefer giving levoalbuterol than giving albuterol. Non-selective binding of the receptors can cause different adverse effects, but remember, these are often predictive. Some of the most common agonists we've talked about, the norepinephrine, epinephrine, and isoproterenol, they are common ICU medications, but they are non-selective. But most of if you have to guess on the test about the adverse effects of these adrenergic drugs, most of them are going to relate to either hypertension or tachycardia. We do have some contraindications for alpha-1 receptor agonists, for alpha-1 specifically, so they're contraindicated in patients. We have relative contraindications, absolute contraindications. So an absolute contraindication is a contraindication that you do not give that drug. We don't try to weigh the benefits and risk. If it's an absolute contraindication, we don't give the medication. Then we have relative contraindications, which means that you can weigh the risk and benefits for that patient, and it would be acceptable within the standard of care to prescribe that medication. But contraindications in general are things that you have to be aware of, and you have to decide whether or not you're going to prescribe based on that contraindication. With an alpha 1 receptor agonist, it's contraindication in the following, and I won't read the list. I just want to draw your attention to make sure that you look through these. The primary, prostatic hyperplasia is one that you need to ask about. You don't want to give these medications you don't want to give alpha 1 receptors if they have prostatic hyperplasia. It's a relative contraindication for all of the others that are listed here. With alpha 2, it has to be given more cautiously in individuals with low blood pressure. It's a geriatric patient. If you give them a medication that can cause orthostatic, you have to remind them they have to stand up slowly, they may fall. They may just get dizzy and fall no matter what your patient education is. And also it can have some sedating effects. So if you will have patients that are driving, geriatric patients that are driving, even middle-aged patients, if you have, depending on the dose, you can get lightheadedness and dizziness that can result in falls. Beta 1 receptors, because you're affecting the heart directly, you have to be cautious in patients who have arrhythmias. You have to be cautious in patients that have heart block for obvious reasons. And then epinephrine is contraindicated in closed-angle glaucoma. Now, this might sound like it's not important, but it is something that comes on the test quite frequently. And when they bring your attention to a drug that should not be used with closed-angle glaucoma, make sure you know that, because that sometimes comes on the test. And epinephrine is an example, but there are some drugs that we use in the outpatient setting that are contraindicated in patients with closed-angle glaucoma, and they do like to test on those. You have to watch for heart rate and the effects on the heart and the effects on the blood pressure. That's really the point that this slide is making. Which drugs are going to cause this effect more often than others? And that's the alpha 2 agonists and the beta 2 agonists. So alpha 2 agonists, remember the alpha 2 agonists are the receptor class that's kind of de-emphasized. We really focus on those alpha 1 agonists in terms of our treatment. And remember that very first slide about the alpha 2, there wasn't a lot there other than the fact that, there was that negative feedback effect on norepinephrine and the effect on acetylcholine. So if you give an alpha 2 agonist, then you have to monitor these patients for bradycardia, hypotension, and substance abuse. And then for the beta 2 agonists, you're going to have to, now we did talk quite a bit about beta 2 agonists because these drugs are certainly used for treating chronic obstructive lung conditions. This one we have to monitor the patients for paradoxical bronchospasm, the effects on blood pressure, the effects on heart rate, and the effects that you can get on the central nervous system, which may be dizziness and confusion. Epinephrine is a drug that we spend a lot of time on. I do think it's a drug to be familiar with. I think it's kind of like I tell students about DIG. You want to know everything about epinephrine just because it's high yield. It is a drug that they like to ask about. It's used in so many settings, and it's used in so many critical settings. Remember, this is our drug that we use in cardiac arrest, and it's also the drug that we use in the ICU in critical patients.